High-risk prostate cancer. So high-risk prostate cancer includes Gleason 8 to 10 disease, PSA greater than 20, T3A to T4. Very high risk is T3B to T4, Gleason 5 primary, or greater than 4 cores with Gleason 8 to 10. You should have also obtained additional CT or MRI staging, bone scan, PSMA, C11, or Axeman PET. For high-risk prostate cancer, that's N0, M0, you have a few treatment options. The first is external beam plus long-term ADT. Between 18 and 36 months, you can start the ADT with the radiation per Dan Spratt. The dose fractionation schemes include 60 gray and 20 fractions of whole pelvic RT, treating the prostate, seminal vesicles, and lymph nodes for a lymph node risk of 20% or higher as follows. 70 gray and 28 fractions with an SIB to 45 gray and 26 fractions for the nodes, or 68 gray and 25 fractions with a 50 gray whole pelvic RT SIB per pop RT. Additionally, you can do radical prostatectomy with pelvic lymph node dissection. Consider docetaxel added to radiation and ADT for very high risk or Gleason 9 to 10. Consider plus or minus abiraterone in very high risk disease, meaning at least 2 of T3 plus disease, Gleason 8 plus, or PSA greater than 40. For clinically node positive on imaging, again, EBRT with 6 to 36 months of adjuvant ADT. Typically will be 70 gray to the prostate, 45 gray whole pelvis, common iliacs, internal, external iliacs obturator coverage. Consider abiraterone and prednisone added to EBRT plus ADT. Alternatively, you can do radical prostatectomy plus pelvic lymph node dissection with adjuvant ADT if they're pathologically node positive and external beam as indicated per path. You can also do ADT plus or minus abiraterone plus prednisone alone. If the patient has a life expectancy of less than 5 years and is asymptomatic, you can do ADT or observation. If they're pathologically node positive after radical prostatectomy or pelvic lymph node dissection, you do adjuvant external beam and ADT if 1 to 2 lymph nodes positive and Gleason 7 to 10 and PT3B to T4 or margin positive, or if they had 3 to 4 lymph nodes that were positive. If they have nodal oligorecurrence after prior prostate-directed local therapy, there are a lot of things you can do. Salvage pelvic lymph node dissection, plus or minus EBRT, plus or minus ADT. You can do EBRT plus ADT, SBRT plus or minus ADT, or ADT alone. DeBlazer et al. Show that pelvic nodal RT decreases recurrence but increases toxicity compared to SBRT. Brave et al. Salvage pelvic lymph node dissection alone is insufficient. There's a 10-year freedom from biochemical failure of only 11%. 10-year prostate cancer-specific mortality is 34%, but improved with ADT. The oligopelvis trial, 6 months of ADT plus pelvic IMRT, 54 gray and 30 fractions with an SIB to the devil's number, 66.6 gray to PET positive nodes. 3-year progression-free survival is 58%. This is my favorite option. M1B is metastatic disease with one of the following. You can do ADT with apalutamide, abiraterone, docetaxel 75 milligrams per meter squared for 6 cycles, or enzalutamide. You can also do EBRT to the primary, 50 to 55 gray and 20 fractions per stampede, but only if they're low metastatic burden, meaning 1 to 3 bone mets or non-regional nodal mets. There's no data on doing this with concurrent ADT. Please keep that in mind. Bisphosphonates for bone mets, radionuclides, including strontium, which is a pure beta emitter. There's bone marrow suppression. Nadir 3 to 6 weeks follows CBC for 3 months. Samarium is beta and gamma emission. Radium-223 for symptomatic bone mets if they have no visceral mets. This is different from the others because it has a survival advantage. It's given IV monthly times 6 months. Sapulocil T if they're asymptomatic. Improved median survival. There's no published trials yet of SBRT to synchronous oligometastases. Metachronous oligorecurrence after primary treatment of the prostate. You can treat per Saber Comet, Stomp, or Oriole. ADT can be started 6 to 8 weeks before radiation, day 1 of radiation, or after completion of radiation, but adjuvant is now favored per Dan Spratt. 2020 Lupron is again 7.5 milligrams per month. You can consider bicalutamide 2 weeks leading up to LHRH agonist. Daguerreolex is sub-Q, 240 milligrams loading dose, 120 milligrams per month. Pelvic lymph node radiation for very high and high risk, consider for unfavorable intermediate risk. The evidence for this, radiation plus or minus ADT improves overall survival by 10 to 15% with 2 to 3 years of ADT. RTOG 8531, RTOG 8610, EORTC BOLA trial, RTOG 9202. This is the main one I'd highlight. PCS for 18 months, 36 months has the same overall survival. Primary endpoint was overall survival here. It was powered for superiority, expected to improve 5-year overall survival from 70 to 79%, actual 5-year overall survival 91 versus 86%. Only 58% of the 36-month ADT arm got the full duration versus 88% of the 18-month arm, so is there a bias towards the null hypothesis? There was no statistically significant difference in overall survival, disease-free survival, or cause-specific survival. 18 months had improved testosterone recovery and quality of life. Other important trials here. Field size, whole pelvis is used in all high-risk trials. Dose escalation, ADT plus or minus RT. You never do ADT alone for high-risk disease. SPCG7 Scandinavian increased overall survival at 10 years for radiation plus ADT for high-risk disease. NCIC. EBRT plus Brachy, Ascend RT, pop trial, Ascend RT to heaven, N equals about 400, intermediate 1/3 and high risk 2/3 prostate cancer. They got 8 months of neoadjuvant ADT, then they got whole pelvic RT, 46 gray and 23 fractions with ADT for 12 months ADT total. Then randomized to LDR, a Brachy boost, 115 gray with iodine 125 and 2 months of adjuvant ADT versus EBRT boost, 78 gray total with 2 months of adjuvant ADT. Results, there was no difference in overall survival, cause-specific survival, or distant METs, but biochemical progression-free survival improved with Brachy. 15-year biochemical progression-free survival is 80% versus 53%. There was worse toxicity with low dose rate, however. The grade 3 GU toxicity was 18% versus 5%. GI was 8% versus 3%. Both were worse for brachytherapy boost. Bottom line, LDR boost after EBRT in intermediate and high-risk prostate cancer improves biochemical progression-free survival compared to EBRT alone, but at the cost of a statistically significant worse GU toxicity and maybe worse GI toxicity as well. Of note, men randomized to the Brachy boost were 2 times as likely to be free of biochemical failure at a median follow-up of 6.5 years, but at the cost of worse acute and late GU toxicity. There was a non-statistically significant trend to worse GI toxicity with Brachy 2. There's no overall survival benefit to Brachy, however. There's a TROG 03.04 radar trial, which is looking at high dose rate Brachy boost, which is optional, favorable outcomes with HDR boost plus 18 months of ADT. Techniques here, whole pelvis RT, whole pelvic IMRT for lymph node risk of 20% or higher. This includes the common iliacs, external iliacs, internal iliacs, obturator, and presacral nodes. You then cone down to the prostate and seminal vesicles. If the patient is T3B, treat the entire seminal vesicles. Option 1 would be 60 gray and 20 fractions to the prostate. Nodes get 44 and 20. This is Profit Chip and NCI Rome. Option 2 is 70 gray and 28 fractions to the prostate with 45 to 52 and 26 to 27 fractions to the nodes, RTOG 0415. Option 3, 68 gray and 25 fractions with 50 gray whole pelvic RT, SIB POP RT. If you have gross nodal involvement, treat as high as possible, ideally up to the dose being delivered to the primary tumor. Volumes, NRG Pelvic Lymph Node Atlas 2021. Your CTV is a 7mm vessel expansion cropped off the muscle, bowel, and bone. Your common iliac nodes commence at the aortic bifurcation, approximately L4, L5. Then you carry them down as they split to external and internal iliac. The external iliacs you taper off as the external iliac vessels cross beneath the inguinal ligament near where the mid-femoral head is located. The internal iliacs, the posterior border, should extend to the anterior surface of the piriformis. Your obturator nodes extend to the posterior edge of the obturator internus, taper off at the top of the seminal vesicles or the prostate bed if it's post-op, end at where the seminal vesicles join the prostate or at the mid-bed. You also want to contour prevertebral, mesorectal, presacral nodes from L5 to S1 down to S3, basically from sacrum to 1 centimeter anterior to the sacral bone. Your PTV is a CTV plus 5 millimeters. Cone down to prostate and proximal seminal vesicles or the entire seminal vesicles of T3B. Again, boost grossly positive nodes as high as possible while still meeting bowel constraints. Trials here, POP RT was whole pelvic RT versus prostate only. These were node-negative prostate cancer patients with a lymph node risk of 20% or higher per Roche. 80% had a PSMA PET. They either got prostate-only radiation, 68 gray and 25 fractions, versus whole pelvic RT, 50 gray, plus 68 gray SIB to the nodes with superior border at the common iliacs. Both arms had ADT for 24 months. Bottom line from this trial, whole pelvic RT with elective nodal irradiation improved biochemical progression-free survival, distant metastasis-free survival, and disease-free survival, but with increased late grade 2 toxicity, but not grade 3 GU or grade 2 to 3 GI toxicity. Palliation considered 50 gray and 20 fractions. Toxicity follow-up outcomes, 60% biochemical progression-free survival, 85% cause-specific survival with IMRT and ADT. Overall survival at 10 years is 40 to 50%. Lymph node plus prostate treatment. ADT side effects, cardiac toxicity, D'Amico, JNCI, 2007, 5.5% versus 2% at 5 years. Bone density, follow this. Give 1,200 of calcium and 1,000 units of vitamin D daily. Get a baseline DEXA scan, then annually. Add denosumab and monitor calcium, zoledronic acid. Check creatinine or alendronate for high-risk fracture by FRAX criteria. Libido and impotence, muscle loss, fat increase, hot flashes, anemia, metabolic syndrome, and gynecomastia. To prevent gynecomastia, 4 grade times 3 to 5 centimeter circle around the nipples using 6 MeV electrons to the 90% isodose line. You must do this before you start hormones. If you have seminal vesicle invasion with adherence to the small bowel, there's a 10 to 50% risk of small bowel damage with ulceration perforation, but would still recommend treating to full dose secondary to recurrence risk.